This conference will now be recorded.
So coming to adhesions, most commonly after post-operatively. It's common after lower abdominal and gynecological surgery. So these adhesions are relatively, to prevent adhesions, a number of modalities are being tried. One important thing we should remember while operating any patient is adequate hemostasis, good hemostasis and gentle handling of the tissues can prevent adhesions. So laparoscopic surgery has less adhesions compared to open surgery because of gentle and atraumatic handling of the tissues. So in case of post-operative adhesions, the patient can present early as within 4 weeks, but most commonly they present roughly few years after the surgery. So second is the inflammatory conditions. In our country, we need to rule out tuberculosis. The tuberculosis adhesions are more common. It involves ileocecal region and secondary peritonitis, pelvic inflammatory disease in most is the females, and cholecystitis and appendicitis, inflammatory pathologies. These inflammatory pathologies, if the inflammation is severe, they can result in adhesion formation in structures like cholecystocolic fistula, uh, cholecystitis, and gallbladder and duodenal adhesions. All these conditions are common. So adhesions, most important, you need to remember post-operative and inflammatory. So this is the, if you take a look at this picture clearly, here you can see the dilated bowel and the collapsed bowel. This is the adhesive band which is causing the obstruction. So the treatment here includes the simple adhesiolysis. This is the adhesive obstruction. Adhesion between these two of bowels, if it is circumferential, it can overlap the entire intervening segment of the bowel. Adhesiolysis, which can be done either in laparoscopic or open surgery. So if in these cases laparoscopic surgery is to be performed, great care is to be taken to avoid bowel injury. Next common causes is hernia, and is external visible causes like inguinal hernia, femoral hernia, and umbilical hernia. So internal hernias within the defects of mesentery or in the ligaments surrounding the viscera. So foramen of diaphragmatic hernia, defect in the broad ligament, defect in the mesentery or the transverse mesocolon, or duodenal, paraduodenal, and pericecal hernias. Most commonly, all these conditions because of congenital defect in the surrounding tissues, paraduodenal, pericecal, and appendiceal retroperitoneal foci. This is the internal image of the internal hernia. So here the bowel can enter a naturally occurring space or a space created secondary to iatrogenically created space. Like in bariatric surgeries, there are spaces like Peterson space and jejunal defects. All these, the bowel can invaginate into these portions and gradually become obstructed and strangulated. So this is the strangulated inguinal hernia. This picture clearly it shows most commonly the obstruction in case of inguinal hernia lies at the superficial inguinal. Because of this obstruction and external pressure, there will be a radial cutoff of blood supply, and gradually, if the patient is unattended for in the early stages and the obstruction not relieved, it gradually progresses to strangulation. Arterial supply gets cut off, and then venous return is also compromised, leading to this gangrene of the bowel. It's a septic state, and it should be proceeded to surgery urgently. At surgery, after opening and getting access to the bowel loop which is strangulated, we need to examine if there is minor discoloration or minimal peristalsis. Then the condition in which we need to assess the vitality of the bowel. We need to place warm saline mops over the bowel, and the patient should be administered 100% oxygen, and for roughly a period of 10 minutes or so. And then the condition of the bowel and the peristalsis, color of the bowel, mesenteric pulsations, all these are re-verified. The vitality of the bowel is confirmed. If the bowel is viable, then we can reduce the contents into the peritoneal cavity and perform a simple herniorrhaphy. In septic conditions, we don't use a mesh. Whereas if the bowel is not viable, then we need to plan for a resection anastomosis of the small bowel or large bowel, whichever is involved. So in those cases requiring bowel resection, we need to assess the status of the other bowel also. So the grossly discolored and the gangrenous bowel should be resected, and then depending upon the conditions, end-to-end anastomosis or anti-side anastomosis can be performed. So in large bowel obstruction, mostly neoplasms, colorectal malignancies are more common. So we need to rule out cancer in cases of large bowel obstruction. So most of the colorectal malignancy they occur in the region of the rectosigmoid region. So roughly about 15 to 20% of the colorectal cancers they may present as obstruction. Generally, the symptomatology of the right versus left colon or ascending versus descending colon pathology is right-sided lesions or ascending colon lesions present with anemia or chronic blood loss, whereas in case of left-sided obstruction, the lesions are constricting in nature. So this constricting lesion gradually compromises the lumen of the large intestine, and it leads to obstruction. When the lumen of the bowel is compromised beyond a certain point, there will be obstruction. Coming to strictures, congenital it is intestinal atresia, and in the younger age group, you need to remember two important diseases like Crohn's disease and tuberculosis. Crohn's disease, while you are operating for Crohn's disease, the most important condition you need to remember is you need to preserve the length of the bowel. Well, as Crohn's, it can affect any part from the mouth to the anus. Any part of the GI system can be involved. So preservation of the bowel length. Bowel conservative surgery is preferred in Crohn's if feasible versus resecting the bowel, because the patient may need multiple surgeries later in the course of the disease, so which could gradual resection can lead to small bowel syndrome. So we need to preserve the length of the bowel. So to preserve the length of the bowel in these strictures, things which we commonly perform is a stricturoplasty. Depending upon the length of the segment involved, there are various types of finis and chemicals, jabulase, Michelacci, stricturoplasty, various types of stricturoplasty depending upon the length of the segments involved and condition of the adjacent bowel. One more important condition in our Indian subcontinent is tuberculosis. Coming to the neoplastic, lymphomas and carcinoids can with strictures. So volvulus. Volvulus means twisting or rotation, axial rotation of the bowel about its mesentery. So it could be primary or secondary. Primary most commonly congenital or secondary it is acquired. So In case of intestinal malrotations, this is image of intestinal malrotation. There are three types of complete malrotation or non-rotation and partial malrotation, like in which cases either the coccolliculum or the DJ flexure, one of those might be involved. So in these conditions, one important aspect you need to remember is there will be lat span between the colon and inside the abdominal wall. So these lat spans, which here in the image they are extending from the cecum to the abdominal wall, they can obstruct this duodenum, the underlying bowel. These adhesive bands can cause obstruction of the duodenum. So this is the typical picture of a volus. If you clearly take a look, it shows the image of being inflated tire-like appearance, ballooning and stretching of these vessels involved. And if not repaired in the early stages, it could lead to strangulation and then gangrene of the bowel. Coming to the intussusception. Intussusception means imagining of proximal part of the bowel into most distal part of the bowel. So segment of the bowel which is imaginating is the intussusceptum, which is the segment of the bowel into which the intussusception takes place is the intussuscipiens. Most commonly it is antegrade. The most common location involved is ileocolic, and it could be colic and colocolic or ileoileal, but the most common condition is ileocolic, ileocecal. So primary intussusception, it is in infants and young children because of the lymphoid hypertrophy of the terminal ileum. So in these conditions, in primary conditions, the classical feature is passing of red currant jelly stools. Secondary intussusception is more common, is typically seen in adults. Here you should rule out underlying carcinomata or other any lead point. So the lead point, there is a pathological lead point. So in cases of secondary intussusception, which occurs in adults, we need to address the lead point. So most commonly, resection or treatment of the lead point is done. Whereas in case of primary intussusception in children, you can attempt various conservative methods like contrast enema, suction, hydrostatic suction, and pneumatic suction. All these conditions can be tried before proceeding into surgery as a last resort. But in case of secondary intussusception, there will be a pathological lead point. This lead point could be anything like a polyp or Meckel's diverticulum, submucous lipoma or hemangiomas, and lymphoproliferative disease, all these conditions. So depending upon the pathological point, if it is either a malignancy or some, most commonly we need to resect the thing. So this is the image, classic image of here the ileum is entering into the colon. So this colon portion is known as intussuscipiens. This ileum which is entering into the colon, this is the appendix, this is the ileocolic junction. So the distal small wall, distal terminal segment of the ileum, it is entering into this colon. So this terminal segment of the ileum is known as the intussusceptum, and the colon into which it is entering is known as the intussuscipiens. So this part which first enters is known as the epic, and then the neck of the intussusception. Different parts are present for the intussuscipiens, intussusceptum. This is the jejunal intussusception in case adults. Here, most commonly, there will be a lead point like a underlying submucous lipoma or a polyp, or could be a hemangioma. All these conditions can lead to jejunal intussusception. So, coming to the bolus obstruction, gallstones. This pathological condition is known as gallstone ileus. So classically, the infection is 60 centimeters proximal to the ileocecal wall. Is most commonly seen in elderly female patients. So these gallstones, which attains a large size, gradually travels to the through the fistula to which it is connected either to the duodenum. Most commonly, this fistula is either duodenal fistula or polycystic fistula is present, and these stones travel through the fistula into the bowel, and it causes obstruction of the bowel. So, focal impaction secondary to food is also seen in some cases of patients are randomly ingesting unchewed particles which are not digested in the gastrointestinal tract. There are various conditions. Few years back, we operated on a case of intestinal obstruction in which the cause is impacted a mango pick. Few of the mango pickles. These things they obstruct the bowel of the patient, which went undigested, and gradually it led to obstruction. So impacted food particles and some fruits which without proper chewing and without proper even in most commonly seen in children, if they accidentally ingest, it could obstruct the intestine. So the stercolith, it is associated with the jejunum diverticulum or the ileal stricture. So trichobezoar, it is most commonly seen in females associated with psychiatric disorders, various psychiatric disorders. So it is secondary to the firm mass of undigested hair balls. The cuticular lining of hair is relatively resistant to the digestive enzyme. So these patients they are more commonly associated with psychological disorders like trichotillomania, which means these patients they randomly pluck the hair and then ingest the hair. So gradually, repeated bouts of the similar incident, it can lead to stagnation of all these hair follicles either in the stomach or in the small bowel, and gradually leading to most commonly it is in stomach. So these are resistant to the enzymatic digestion, and it forms a firm masses of undigested, just like about well, in children or in younger cases where it is the load of the disease is minimal, you could try enzymatic therapy like PEP in another cola therapy and all. These things they can dissolve these tissues, and it can promote their intestinal transit. If it is not the case, then the option is surgery. We more commonly do a gastrotomy. So there is a minor glitch. So in these cases, we perform gastrotomy and then we evacuate the entire mass of this firm trichobezier and then switch it back. These patients need psychological counseling also to prevent further episodes. Post-operative psychotherapy is also advised. So this phytomeasurements form of organic material like fruits or vegetable fibers. Some fruits which if we don't properly chew them and grind before ingesting, this could lead to firm masses. These are known as phytomeasure. Worm infestation most commonly seen in children. Most commonly it is implicated is Ascaris lumbricoides. This is a segment of the bowel resected with most commonly these roundworms after they die because of the because of the pharmacological therapy. These worms die and they form a mass in the small bowel and gradually it leads to obstruction. So coming to the aerodynamic obstruction, here there is no mechanical factor involved. The only factor involved because of this paralytic ileus. Paralytic ileus means the reflex inhibition of the peristaltic activity because of increased sympathetic drive. So here the smooth muscle it becomes unresponsive to the neural and hormonal stimuli. So most common causes post laparotomy, post abdominal surgery, and pelvic surgery. There will be a period of failures, and then the motility of the gastrointestinal tract gradually returns back. Colon is the last to return. Uh, colon is the last organ then whose motility returns back. So in post-operative cases, we do examine for bowel sounds before initiating any oral therapy, initiating any oral feeding. So most commonly, the paralytic ileus could be secondary to the intra-abdominal sepsis, like conditions like cholecystitis and appendicitis, and abdominal pelvic trauma like retroperitoneal hematoma. This presence of any reactive fluid in the abdomen could lead to paralytic ileus. Other contributing factors include electrolyte imbalance, uremia, and drugs like narcotics, anticholinergics, and phenothiazines. So this acute colonic soda obstruction, it is also known as Oglieve syndrome. So it is a massive colonic dilatation in the absence of any mechanical blockage. So it commonly affects the cecum and the right colon. There won't be any mechanical factor involved. Also known as Oglieve syndrome. So it commonly occurs in elderly hospitalized patients with a major trauma, illnesses, and other surgeries. So major non-operative trauma, sepsis and myocardial infection, and prolonged blood and hospitalized patients like orthopedic surgeries and gynecological surgeries, cerebrovascular accidents, spinal cord injury, advanced malignancies, and respiratory and renal failures. There are some drugs implicated. First, we need to inquire about the medications which the patient is receiving, like opioids and phenothiazines and calcium channel blockers. So next is the acute mesenteric ischemia. Previously, embolic diseases used to be more common. Now, now the stats indicate that thrombotic diseases are also similarly common. So embolic disease it most commonly affects the SMA because of its angulated origin from the superior mesenteric artery, most commonly at the level of origin from the superior mesenteric artery. Embolus is seen. So embolus is a secondary embolic mesenteric ischemia. It is secondary to various valvular heart disease like atrial fibrillation and mural thrombosis in case of MI. Thrombus because of acute thrombus and pre-existing atherosclerosis. Oh. And in conditions of shock like hypovolemic and septic, there is one more condition known as a non-occlusive mesenteric ischemia normally. So coming to the pathophysiology and presentation of intestinal obstruction. So in case of acute obstruction, there will be sudden and severe central colicky abdominal pain. Colicky means the pain reaches a threshold. It reaches a peak, and in between there will be a normal period, and later it repeats. So this type of pattern of pain is known as a colicky type of pain. So vomiting, it can contain, depending upon the level of obstruction, it can contain partly digested food, mucoid, or greenish or feculent. Feculent is more dangerous. Greenish means in the presence of bile distal to the second part of the duodenum obstruction. You can estimate if there is a the vomitus contains bile, you could roughly assess the level of obstruction to be distal to the second part of the duodenum. There will be abdominal distension, and there will be absolute patient cannot pass stools, absolute constipation. In severe cases, which the patient cannot even pass flat, which is known as obstipation. So in case of chronic obstruction, patient in known case of there will be known case of constipation, abdominal distension, and abdominal bouts of colicky pain in the hypogastrium. So here the vomiting is not early vomiting; it is delayed for 2 to 3 days. So the physical examination, you need to assess the abdominal distension by measuring the girth of the abdomen. You need to assess for a previous scars, previous surgical scars, which could cause adhesive type of obstruction. And you should assess the visible peristalsis, stepladder type, and in palpation, you can a mass can be palpated either in case of inguinal hernia or malignancy. Tenderness, guarding, or rigidity will be there. In percussion, because of the gaseous distension and all, there will be tympanic note and dullness. Auscultation in early stages, because of increased peristaltic movements against an obstruction, there will be the bowel sounds are high pitched bowel sounds are heard. Later in the course of the disease, when it is severe, the bowel sounds may be completely lost. Digital rectal examination, which is very useful in case of intestinal obstruction. You can assess the presence of any stenosis or malignancies. If that is a malignancy, at what distance from the anal, and then you can proceed accordingly. So coming to the investigations, first you need to regular full blood count and clotting profile, and depending upon the condition of the patient, arterial blood gas analysis, creatinine, sodium, potassium levels. So this electrolyte imbalance can also lead to ALS and intestinal obstruction. LFT, glucose, LDH, all these conditions to grade the severity. And as we are planning for surgery, we need to group in typing of the patient. Optional conditions include ESR, CRP to assess the inflammatory status and hepatitis profile before proceeding to surgery. So in radiological, play a crucial role in the diagnosis of intestinal obstruction. One is a plain abdominal X-rays. Here you could clearly see the dilated loops of the small bowel, and depending upon the location of the bowel, whether you could tell whether it is a small bowel obstruction and a large bowel obstruction. There are also various features which differentiate a small bowel obstruction from a large bowel obstruction, like depend after looking at the X-ray, you could differentiate small bowel from large bowel using few things like whether the presence of valvular connectivities or haustra, location of the bowel, either it is located centrally or peripherally. Peripherally means It is a large bowel and centrally located means. And there are various signs like coffee bean sign, and in case of sigmoid volvulus, bent in the tube sign, all these things. And in cases of gallstone alias, you could locate the stone. And in severe cases of closed loop obstruction and all this, you could assess various signs like regular signs, which means the pneumoperitoneum, air or the gas is present on both sides of the bowel. So ultrasound scan can help in identifying various mass-free fluids and the peristalsis pattern. And other advanced conditions which is most useful is CT, either contrast and then CT scan. So this is the X-ray abdomen with the air fluid levels. This is supine with here this loop of bowel which is dilated as a distended small bowel. Clearly you could it is located centrally with a prominent valvular cannulatus. If it is located peripherally and these lines are complete, it means Hostra, and they are located in case of large bowel. So lateral decubitus view, it also depending upon the presence of air fluid levels, you could get is an obstruction. So difference, it is located peripherally and there will be Hostra. Small bowel is located centrally. There is valvular cannulatus. So this is the image showing various air fluid levels, multiple air fluid levels. So dilated colon means more than 6 centimeters, dilated small bowel more than 3 to 4 centimeters. There will be effacement of the Hostra, peripheral location, and multiple air fluid levels are fluid. In examining these X-rays, there is a rule of 369. So if small bowel is dilated 3 centimeters, large bowel dilation is greater than 6 centimeters, or cecum greater than 9 centimeters, you need to suspect intestinal obstruction. This is cecal volvulus or the cecal bascule. So here this volvulus is pointing towards the right ilia fossa. This is an image of sigmoid volvulus. Okay. In this image, you could clearly appreciate the dilated large bowel which is located peripherally. So here, this is the intussusception. There are various signs like Clausen and all. So CT, it can be used with non-contrast, but contrast CT is more useful in case of intestinal obstruction. Triple phase means intravenous, oral, and rectal contrast. So it can help demonstrate abnormalities in the bowel wall, mesenteric wells, and the peritoneum. It can define the level of obstruction, the degree of obstruction, the cause like volvulus, hernia, and luminal and mural causes, the degree of ischemia, and whether there is any free fluid or gas present. So this image, it could clearly show the dilated bowel loops on the patient chart. This junction between the dilated and the collapsed bowel loops is most commonly the site of obstruction. So here the cause of obstruction, these are the rectus muscles in the midline, posterior vertebrae, and in the midline you could clearly see something coming out of the central region and occupying the subcutaneous region and all. So here, depending upon the level, this patient is reported to having this umbilical hernia. This You could clearly appreciate the gap and the contents reaching above. So barium gastrographin, it should not be used in patients with peritonitis. It is used either through barium meal or barium follow through or barium enema. It is useful in recurrent and chronic obstruction. It can distinguish adynamic obstruction from dynamic obstruction. So this is bird beak sinus valvulus and coil spring or coil stack appearance in case of intussusception. This image. So today we'll finish by discussing the management of small bowel. So one important thing you need to remember before treating any intestinal obstruction cases, there will be fluid loss because of third space accumulation. So third space fluid loss are more prominent, and extra and intravascular fluid which is available for hemodynamic maintenance is reduced. Because of this third fluid loss, we need to first correct the hemodynamic status of the patient by giving the patient fluids and correcting any electrolyte abnormalities. So if the patient presents with the signs of a small bowel obstruction, first you should verify whether the patient is clinically stable or not. If he is not stable and the condition is rapidly progressing with hypotension, and if the patient is in shock, you need to proceed with the exploratory laparotomy after grouping and typing in informing the anesthetist regarding the condition of the patient. If the patient is clinically stable, then you have sufficient time for workup. Then you need to proceed with investigations like radiological investigations like radiography, X-ray of abdomen, or CT. Nowadays, CT abdomen is more commonly used because of in these conditions, if CT can reveal any vascular compromise or perforation, whether the obstruction is complete or not, or if it is partial. So if there is vascular compromise, you need to immediately proceed with the exploratory laparotomy. If it is not or if it is complete obstruction, then you need to give the patient intravenous fluid, stop from oral intake, nasogastric intubation and right tube aspiration, and intravenous rehydration, intravenous fluids to correct the patient's fluid status. If it results in roughly in 24 to 48 hours, you can advance to diet, and depending upon the image findings, the patient can be treated for that particular disease or whichever is causing. If it is not, then you need to proceed with the exploratory laparotomy. If the obstruction is partial, you need to withhold the patient from oral intake. Similarly, rehabilitation patient and the resuscitation of the patient measures are similar in case of complete and partial obstruction. Here also you will place a nasogastric tube. Sequentially, you need to measure the abdominal girth of the patient, and any rapid increase in the girth of the patient more than 5 centimeters is an indication for exploratory laparotomy. If it fails to resolve in 24 to 48 hours, then you need to proceed with other investigation. If it is partial, then upper gastrointestinal or small bowel follow through and enteroclysis. If it is resolute, you can initiate diet after some period. If it is not, then you need to proceed with the exploratory laparotomy.